Good evening. This is Dr. Bill Wyatt with the American Orthodontic Society, and I'm going to talk to you a little about understanding the TMJ pain, or at least part of it. Now, this pain came up from the position of the jaw. It was being forced back by the teeth. Now, you can have trauma and stress and arthritic conditions and several other pain causes, but the vast majority of it is the way the jaw is being pushed back by something. And it can be a crown, it can be the actually interdigitation of the teeth. There's just so many ways, but I want each person that's doing orthodontics to understand this pain. And this example right here I'm going to show you is some international speaker. I went to hear him 3 times, and then a young man that was in one of his classes told me about how he got rid of this pain. He did not know any orthodontics. So let's get started with this now. This is just the lower arch. There's no problem there. Let me see now. This is a beautiful young lady, but she has a class 2, division 2 problem. In other words, the upper front teeth are sticking back like that, and she really has one. And it doesn't detract from her looks. Her jaw is back short. You can see the jaw really needs to be out here somewhere like that, just about as far as the teeth would show. But a very pretty young lady, even with her jaw back like that. And we mix some stress in with this, but I think the positioning of the jaw was the main cause of the problem in here. Now here is the class. This is a classic class 2, division 2. Now these front teeth need to be out here, and they're back here, and the roots are going up in this way. Now they have trapped the jaw back, and the jaw wants to move forward right in here. Now that's not the problem in it, but the condyle. You've got the fossa back in here, and well, I can't draw it in there. Anyway, the condyle is too far back, and it's shoving into this retrodiscal tissue. I've got a whole video on that if you'll look it up, or if you look up this video these 2 men from Sweden showed. It is so helpful to you. Just flat memorize it, if you will. Now this is shoving the condyle into this retrodiscal tissue, and this is giving this young lady a lot of discomfort. But hers wasn't all that bad. And I talked with her and decided it wasn't just stress or anything like that, but she needed her jaw to come out to here. I mean, like this distance right here. Like this spot really ought to come under there. That would bring these teeth out to here. So it's right in the middle of these teeth that are leaning back. And I said, this is going to make an odd splint. You'll have to be way out here. Give me a few weeks or a month or 2 and let me see what I can do with these teeth and see if we can get some relief from it. And so she had agreed to that. And so I'll show you what we did. Now, before we go into that, I want to tell you what, there was a young man in one of my lectures that was in the lecture of this TMJ patient, speaker, who was international, spoke all over. I heard him 3 different times, very knowledgeable about it, but he did not know orthodontics, any orthodontics, and that is what hurts me. Why we don't teach the orthodontics. Now, what he got a lady in from Ohio, I think, and it had been hurting for months and months and maybe years, and she just came in with her husband, heard about this man. He was down in Alabama. He came down and from there, he got in the hotel, came into his office, and he looked at her and he figured out her jaw needed to be out here. And the same thing we figured out, you know, it's simple. But he knew no orthodontics. So he deadened these teeth and ground them off. Can you imagine grinding the front teeth off and did root canals on them and sent her home back to the hotel? She came back the next morning and hugged his neck, said it was the first night sleep she'd had in I don't know how long. Now that actually happened, at least it was the way this young man told it to me, and that happened. So this is what I'm stressing. Why don't we teach people orthodontics, even if they don't do all of it, they would know something can be done. I mean, they come, for one time back when I first got into this, they thought, well, if they know orthodontics, they'll go in there and just mess up the cases. Well, this case is messed up because they didn't know anything. So I think that knowing doesn't cause as much of a problem as not knowing. And so this guy is a national speaker and a good one, and worked with an oral surgeon. And he did not know that he could move these teeth up out of the way. So let me show you what we did. It took a month, about 2.5 months, I think, to get them out of the way. And the pain primarily went away. Okay, let's go now the other side of the mouth the same way. See this? This tooth right here ought to be out here. This spot right here ought to be out here. In other words, this molar here should be closing like that. And the jaw is trapped back because it can't go forward against those teeth right there. And this is causing pain in this retrodiscal tissue, or the condyle is being shoved into this highly vascular tissue that supplies this synovial fluid to the jaw joint. It's a miracle how it goes in and feeds it and carries the waste product out. And we've been over that time and time again. So just learn that if you're going now. So this jaw needs to come forward. So we go in and we're going to talk to her into just letting us work on it a little bit. It looks like the upper centrals are 1/4 of an inch back behind over there, not so much on this side right here. And so we're going to bring these centrals out here and let the jaw follow them. And that's what just knowing orthodontics will do. I had another international speaker. I went to New York to hear him. Now this lady had the teeth were sticking way out, and he had to slide his jaw forward to get rid of the pain, and it left a big gap in here, and he crowned all of these teeth because he didn't have any idea that you could intrude these teeth up here and you wouldn't have to do the crowns back here. And that I had gone to New York to hear this man, spent a lot of money, and I just, it just tore me up that this guy did not know that. All right, here she is, just looking at it from the side. And now looking at it from inside, so we've got a little raise in the tissue down here where these have come in. So we're going to put an intruding arch, to bring these teeth down. And at the same time, we're going to bring these teeth out like that. However, we just did outbending of these teeth to start with. Okay, here it is, looking at it from the front now again, and there it is from the side. The jaw was trapped back, and that's the distance this tooth is from out here, and we're going to bring these out here like that. And when we did, practically all the pain went away. Okay, here's the lower jaw. It's a little, these teeth are going to have to be intruded some down here, but that's no problem for us at all. Okay, when we started out now, we put an intruding arch. In other words, this went way up here. This is in a spring. It comes out of this tube up here and makes a deal, and then goes up. And now we pull it down here, and it tightens that spring up. And we run across the cuspids here and drop it in right here and hook these teeth to it like that. We didn't have anything on the bottom arch to start with. And this was, I think, this was 12/28 of 87 when we hooked this thing up. 12/28. Now that's about 2 days in December, I think, 2 or 3. And we hooked it up like this. And this big wire is up here. The other wire is just kind of helping out, kind of lining the teeth up. But this wire here is coming, it's pulling up in this direction right here. It also pushes down on these teeth back here, but the occlusion holds them in place. And that's why this gadget we have today, this class 2 thing that so many people buy, works as the molars are being bitten together and they don't move very much at all in there. So anyway, there's that thing. And we had it a little long to start with. That's why I put that little circle in it there. Now this is 12/28/87, and we've got this distance here to here, and this is less over here, but this tooth's going to swing out like that. And so I'm going to show it again in March the 15th. And here is March the 15th. That is 2.5 months from the time that these teeth were sticking way back here. This tooth right here moved a good 1/4 of an inch. And the young lady did not complain with it being sore or anything, just the picking up of this tooth right here, bringing it out. And our temporomandibular joint pain greatly went away, but I had sold them on doing a splint before we started, but we had to brought it out in front of these teeth, so we didn't do that, but we put her in a splint. Now we're going to level these bottom teeth out so they can move a little bit further forward like that. And I just want each of you that understand, this picture is not very in focus right here, but we're going to pick these up a little bit more, and we're going to take these down some, and we'll do this partly while it's in a splint. Let me see. Okay. Now, this tooth right here was up against this to start with. The force to bring these front teeth up came from this tooth here. And it has exactly the same force down as this tooth, this area had going up. There's another tooth on the other side. But they chew on this tooth right here. They just do a lot of chewing. So it moved very little, but it did back up some. Actually, it was further up this way when we started in there. So we correct that, but that's no problem at all. And this was lined up like that, and these are out in front, and now the lower jaw can come forward, and most of the pain is gone away by this. Now, here we put her in a splint now and brought her teeth out. You need to have a little bit of distance between the the anterior teeth out here where they're not bumping against one another. And that's the basic thing of a splint, is just holding the jaw in a forward position. And then you've got to put something under the teeth back here so they can chew on something. If you just bite forward on your front teeth, it would relieve you. But if you do any chewing up here, you got to load here and on the joint. So you put the load in between the teeth right in here, and now that takes the force up that way. And you should, I think everybody in any kind of sports where you could get hit ought to wear a mouth guard and have your jaws just a little bit apart. Because when you get hit, you clamp your teeth together. And having this cushion in there means so much and saves a lot of TMJ problems. My little niece got clobbered. She's playing basketball, and somebody went by and the elbow and whopped her in the jaw here and shoved the condyle into that highly vascular tissue and just damaged the heck out of it. And it gave her trouble for months after that. They had to put her in a splint and bring her jaw forward, see, to let it heal up and everything before we could take it out of there. So you can have trauma, but tooth position and jaw position of the teeth make the jaw go where it wants them to go. And so that you can have it putting the condyle back into that tissue too hard, and that's where the vast majority of the pain comes from. But now you can be under such stress. Now this young lady was in love with some young man, and the mother didn't like the man, and she was discouraging her from marrying her, but she married him anyway. And I'm sure that was had some stressful part of this, but the pain went away when we repositioned the jaw here. Now the lady moved to Florida, and there was a young man I'd had the case was real bright in the town she went to, and I sent her to him, and he finished the case up, but I had it pretty well finished. Now here is where this was. Now this tooth was back somewhere like this, and now it's out there, and not only out there, but it's raised up and out there. And that put pressure on these teeth, you see. They are separated, but that'll come back together pretty quick. And now, this is, excuse me, this is a splint. And this is just an upper splint with a ramp on it that you make by pushing your tongue against this soft acrylic, and it hits the back of these teeth and forces them to bring the jaw in this position. Now, there's a little different distance between the edges of the two teeth here, and back here, these teeth are higher up than the other teeth. So we put an intruding oar here and bring these teeth down, and we've got some bend in this to pick these up right in here, so that we flatten both arches out while we're in the splint. Now, I hate to say this, but I think that if somebody is out in the jungles of the wild, they have a TMJ problem, you could figure out where you wanted to close the jaw tooth. Now, all of you have seen Dr. Mike Worley, who's worked in his office, and he was eating, and he'd bite like this, and then he'd bite like this. He'd bring his jaw forward, and then he'd bring it backward and chew. And I watched him do that for a while, and I said, Mike, what in the devil are you doing? And he said, well, I can chew better back here. That's where his teeth fit, but it hurts, and so I chew out here for a while. And I said, my goodness, you've got a joint problem. You just need to have your maxilla move forward some so that your jaw could close where it wanted to and the teeth would interdigitate. And that's the secret of the vast majority of the pain that you'll get with this. Now this, in putting these splints in, you see, these teeth were up higher. So for me to move them out here, I had to separate these back teeth back in here. Now this real smart man up in New York moved this case out, and he got rid of the pain, but these teeth were like this, and he crowns those teeth with these tall crowns. And I had come all the way from Texas to to hear this man. It just made me feel like I had wasted my money. I mean, why didn't that guy learn that he could have intruded the teeth and flattened them out, and he wouldn't have to crown anything in there? So anyway, that's another thing of not knowing any orthodontics. I've had so many wonderful orthodontists help me. I hate to say anything about them at all, but there were a lot of guys that did not want to pass the knowledge on to anybody else. It seemed like the hierarchy in the orthodontic world was that way. And that, to me, if you've got knowledge about it, you will have less chance to screw up a case than you will if you don't know anything about it. So that's where I would differ with him. But this is the way to make a splint. You can take a mouth guard and heat it up if you just open and close your jaw and don't let it touch your teeth. And just do that a little bit and relax it. Your jaw will close where it wants to. If you put your teeth together where the jaw is happy and satisfied, you won't have very many problems with it, you see. So that's the crux of it. So if you do your jaw like that and take a marking pencil and just that you can write on the teeth and show where the teeth hit right here. Now you heat up your little nail and stick it in your mouth. And now you bite together and close the teeth right in that same spot right there. Then this mouth guard would fill in back here and keep the teeth in this position. So if you're having a lot of pain with it, you can make your own splint. At least I have. I hate to tell you this. I don't think anybody's going to screw them up. I mean, you hurt it, really. It might help a lot of people to know that you can actually help the TMJ pain by doing that. Now, I'm sure I'll get some people who fuss at me for doing this. All right, here we brought the jaw forward. Now you know this point we bring this out here. And so that is the right position. And now we're going to level this out, level it, and level this out. And that's when we were in the process of doing that. And she married this old boy. And this is an upper splint with a little bit of a ramp, you see, on there that made you bring your jaw forward to fit into that place. And you could, I think I could take a mouth guard and make something that somebody would get rid of the pain anyway. Now you've leveled it out and we now have no pain, but we've got an intruding wire right here. We're going to continue to bring this down. we probably got some upbend in this wire, which picks this up. And she married the guy and moved away before we had the chance to actually finish it. But I sent her to a very knowledgeable young man, and he finished the case out. And I appreciate you watching this. My voice is terrible, but if you can learn this, just look at this pictures. Look at the pictures of the condyle. It gets pushed back in the fossa back here, but it's pressing into this highly vascular tissue, and it messes it up, and that screws up the whole thing, and it gets sore and swells up and all that. Or you get hit in the jaw and do that, or you have something, some dentist put something in your mouth and he doesn't know a thing in the world about the TMJ, and it makes his jaw go backward and it comes up hurting, and he doesn't even know why it's hurting. So we need to teach people about things that cause pain with his joint. And brother, it hurts. When it really hurts, you can't hardly touch it. So anyway, I'm going to close up. I preached to you enough tonight, and I hope you'll join our organization. We have a channel, and we would appreciate you. We have several thousand people that are subscribing to it, and I hope you'll do that also. So I'm going to say good night, and I'll talk with you later. So hope you got something out of this.